Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
A big hello and thank you to all who are joining us today for this latest edition of the LE&RN Symposium. I'm your host, Dr. Ajit Mule, and today we will be listening to an expert who will be talking about lymphedema and bringing light to the invisible. I just want to give a vote of thanks to all the generous sponsors who have helped us to bring this series to you all free of cost. And with that, I would like to introduce you all to our guest speaker, Dr. Dhruv Singhal. Dr. Singhal is Associate Professor of Surgery at Harvard Medical School, and he also serves as the co-director of Boston Lymphatic Center and the director of BIDMC Lymphatic Center. He focuses on surgical prevention and treatment of lymphedema. And today he will be talking a lot about his work with lymphedema and treating lymphedema patients. Dr. Singhal, floor is all yours, sir.
Ajit, thank you so much for the kind introduction. I have to tell you, in thinking about giving this talk in this forum, I was just really thinking and humbled at just how honored I am to be speaking in this forum. I've been working with LE&RN and really Bill for about a decade. And that's what I was realizing as I was preparing for this talk. And what's happened in a decade and how much LE&RN has pushed, whether it's the Center of Excellence, whether it's the CDRMP research funding, ARPA, LE&RN has been there and really put lymphatics on the map. Even a decade ago, I don't think we could have said that as definitively as we can say it today. So I just want to just briefly say it's been my honor to walk part of that walk with Bill, Ajit, Steve, the entire LE&RN family. And for me, it's really extra special to be able to present some of the work that keeps me up at night in this forum. So again, thank you for having me. And thanks for just being an incredible organization that's just doing right by the patients. So this afternoon, I'm going to be speaking about bringing to light the invisible. My only disclosure is that I do run my own symposium, so I work with many sponsors, including many of the sponsors you saw on an earlier slide. I don't make any personal money from it, but they do fund us to run our symposium. So I do just want to declare that. You know, I was a fellow when I did my fellowship in Taiwan, one of the more prestigious plastic surgery reconstructive fellowships is in that country. And I remember I was at Saturday morning rounds, and Professor Fu Chen-wei, a world-renowned microsurgeon, said this one morning. He said, the master surgeon is the master anatomist. So if you want to be a really good surgeon, you better really know your anatomy. And at the time, I didn't know I was going to be a lymphatic surgeon. It actually wasn't on my radar. It kind of hit me in the face when I was out in Taiwan, and I saw these incredible lymphatic procedures being performed. But years later, as I dove into lymphatics, and I was a lymphatic surgeon, it hit me that the statement by Dr. Fu Chen-wei could easily be translated into lymphatics, where the master lymphatic surgeon is the master lymphatic anatomist. But the problem with this statement is it's really hard to become a master in lymphatic anatomy. If you look back at textbooks, compendiums, textbooks which really go over all of the lymphatics in the human body, you have to go back to 1787, Mascagni, 1874, Sappey, and then 1938, Rouvier. And that's it. There's been nothing since 1938, nothing that incorporates modern imaging to kind of delineate lymphatic anatomy in the human body. Now, I want to be clear, I'm not taking away from world-renowned anatomists, and I'll be talking about many of them through my talk, but that are doing work, but as a compendium, putting it all together, that actually hasn't happened in close to a century. And so I think it's really important for this field of lymphatic surgery, whether you're talking about vascularized lymph node transplant, lymphovenous bypass, or even debulking, to recognize that we have a blind spot on anatomy, and we need to focus energy on understanding anatomy. And I'm going to share a story that really brought this to light for me. We held our first Boston Lymphatic Symposium in 2017. And we had all our faculty picked, and everyone was slated to come. And we got a call from this French anatomist, Alexandre Pisas, said he wanted to come and give a talk. And, we said, look, our faculty roster is already filled, but if you want to come, you can come give a 5-minute abstract. And he came and he got up and he gave a 5-minute abstract that pretty much forever changed the course of my research. And what he did was, he's an anatomist from University of Montpellier, and in France, and he showed these cases, case after case after case, of women that had breast cancer. And they got an axillary lymph node dissection. They had removal of all the lymph nodes in their axilla, levels 1, level 2. And they didn't get lymphedema. And then they developed some kind of lesion or maybe a skin cancer right here in the upper outer arm. And they went to see a dermatologist, they had it removed, and within a week they had full-blown lymphedema. And what Dr. Pisas stressed to us in that meeting was, it's about anatomy. That it turns out that there is a main pathway that drains the arm, and that gets violated in most cases when you do an axillary lymph node dissection. But there tend to be backup pathways. There can be backup pathways, and these backup pathways can shut that lymphatic fluid around the axilla or the armpit. And if a woman's able to do that, then she's not going to get lymphedema. It's actually the two-hit hypothesis, where you have to take out the main pathway coming out of the arm, and then you have to take out the backup pathway. And the backup pathway that he specifically spoke about was this Sappey pathway. Now, Sappey was the author of one of the textbooks we mentioned from 1874 in France. And so I became very interested in this. I said, this makes perfect sense, as anatomy tends to make sense, especially to a surgeon. And I remember I was sitting in this office. It was on a rainy, long weekend, and I was trying to find information on the Sappey pathway, and I found Sappey's textbook. And I called the Harvard Library, and I said, hey, can you give me a PDF of this textbook? And I will never forget rustling in the background. And the guy came on the call, and he said, we have the textbook. And I almost dropped the phone. I said, wait, do you have this textbook from 1874? And he said, yes. And I still remember it was raining outside. And I ran from my office to the library. It was down in the rare books collection, and here it was. And I remember I asked them, I said, can I take pictures of this? And they looked at me like I was funny looking. And they were like, yeah, you can do what you want. You can touch it. You can open it. And there's Sappey's textbook. There's the imprint from 1874. And I was flipping through it like, I want to find the Sappey pathway. And here it is. So this talk is going to focus on the upper extremity, anatomy, and this right here. This is going to be part of what we talk about. Anatomy is going to be the theme of the talk, but this is going to be one of our opening salvos on anatomy. As you can see here, and I hope you can see my mouse, all these lymphatic channels of the arm are draining to the axilla. But here you see a pathway in the upper outer arm. You can see a lymph node here. We're going to come back to that lymph node later in this talk. And you can see it avoids the armpit, and it goes up into the shoulder, what we call the deltopectoral groove. And this is Sappey's pathway. So this is what Dr. Pisos was mentioning in the symposium. He was like, look, if this pathway is here and it's working well, even if you do an axillary lymph node dissection, the patient's probably going to do okay. But if something happens to this other pathway and there's a double hit, the patient's going to be in trouble and they're going to develop lymphedema. And this speaks to the core of the question that I and really the people in my lab are trying to answer, which is, if you take 3 women and you do an axillary lymph node dissection on them and radiation, why do only 1 in 3 of them go on to develop lymphedema? And we believe, and I'll try to show some data to you over the course of this talk, that we believe this has to do with the anatomy, that women, men, we're all wired differently. We all have variations in anatomy. And those variations in anatomy either predispose you or protect you from developing secondary lymphedema after cancer operations. And the holy grail is, if we can identify these variations up front, we can identify who is at 100% risk of getting lymphedema through personalized medicine, personalized imaging. Well, then guess what? Maybe we can avoid it entirely, either by doing more aggressive lymphatic procedures up front or convincing the breast team that there's a risk-benefit analysis here, and maybe we don't need to dissect that axilla given the stage of the tumor or other cancer characteristics that can make the decision to removing lymph nodes somewhat, a joint decision-making process. All right, so I became very interested in this MS pathway, and I reached out to somebody who's really become a dear friend, Hiroswamy, world-renowned lymphatic anatomist, who's at the ALERT program in Australia. And I invited him to come to our next symposium in 2018. We got a cadaver arm, and he was able to dissect out the arm and demonstrate the MS pathway. And as you can see in this arm, and I hope you can see my mouse again, you can see all these pathways here draining to the axilla, the armpit. But there you go. You see a backup pathway draining up here, going into kind of the shoulder area and avoiding the armpit. And it turns out here we have a close-up picture, and this is in vivo imaging. This is a patient who walks into our clinic. We have a special dark room we can take them into, inject some dyes, and we can actually see these pathways now. While the patient's awake, they can look at it on a big screen monitor as we do it, and we can see if that pathway is present or if different versions of that pathway are present. And so we ended up developing data about the presence or absence or different variations of that pathway, which I'll talk about in a few minutes. And we submitted this to the NIH, and about 5 years ago, we were funded through an R01 to further study the anatomy and function of the lateral upper arm pathway. And we did this by bringing in women who never had breast cancer, and we mapped them using near-infrared imaging, their lymphatic system. We then chased it with nuclear dyes so we can assess which lymph nodes were being drained, and we basically create a baseline map of lymphatic anatomy. And then we brought in breast cancer survivors who never had lymphedema, who had an axillary node dissection, to better understand how did that baseline control anatomy change as we looked at these cancer survivors. And we also had an animal model where we looked at function, but that's outside the scope of what we're going to talk about today. A couple of years later, we were very fortunate. We were further funded through the NIH. We received a U54 grant, which I led and continue to lead, where we were tasked with mapping the lymphatic system in the entire human body. And this really happened with incredible colleagues that came together to work together. Max Itkin at Penn, Dr. Young-Kwan Hong, who was at USC, just moved. He's a preeminent lymphatic biologist who just moved here to Beth Israel and started his lab a week ago with us. Dr. Yanis Vlachos, who runs our spatial technology core, and Dr. Leo Tsai, who's been our lead radiologist for about 8 years. So here we are, we're chugging along, we're studying lymphatic anatomy, and then we got funded by Harvard Radcliffe University. It's the actual undergraduate campus. where they have a call they put out, and it's across the entire university, whether you're an engineer, you're in music, you're in art, and you have to convince them that you have a striking topic where if they gave you the funds to bring in 16 world experts, you could potentially make headway on a very specific topic. And we got funded that year in 2024 to do this. It was a private event, but we were able to bring in 16 world experts on lymphatic anatomy and we felt imaging. We titled it Bringing to Light the Invisible Lymphatic Anatomy of the Human Body, and was focused on the upper extremity. And we had discussions for 2 days. And what I want to go over with you for my remaining time, which I'm going to keep to about 30 minutes, is what were the high-level discussions we had about lymphatic anatomy of the upper extremity and what we're trying to solve. So what did we want to accomplish over those 2 days here in Cambridge? What we were looking to accomplish was, one, we wanted to identify protective upper extremity anatomic pathways. Again, the holy grail, I believe, for secondary lymphedema in the developed countries is when somebody gets diagnosed with a cancer, that we are able to do imaging up front and identify what their personalized risk of developing lymphedema is. Is it 0% or is it 100%? And then work jointly with a cancer team to develop a pathway that prevents that patient from ever developing this disease. And I felt it was not only important to identify the protective pathways, but then we had to figure out how to image, because it doesn't help us if we can identify these pathways in cadavers. We have to be able to identify these pathways in a living, breathing human being. And so these were the two main goals of the workshop, of the think tank, really. And the focus of this talk will be on the anatomy. So there's some pictures just to show you where it was held. It was held on the undergraduate campus in Cambridge. We had our own room. We had, these are two of the leading lymphatic anatomists in the world, Hiro Swami, Miguel Amore from Argentina. We had small group breakout sessions we designed. We also had didactic lectures, and really we were focused on these questions and answering them. We were also able to go to the Harvard Club, have dinner together, and really get to know each other with the goal of also fostering relationships, because this think tank was meant to be a starting point towards answering these questions. And what I want to do is give you an outline of what some of the key features we decided, how we wanted to think about lymphatic anatomy, and then I'm going to do some deep dives into these different systems. So when you look at the skin here, this is your epidermis, dermis, and then you get deeper into the fat, and then you have what we call fascia, and then you have deep fat, and then you have your muscle. And this is meant to be the muscle fascia. We kind of think about the lymphatic system as your superficial system, the things closer to the skin, your deep system, and then things that connect the two. And those are called perforators. Okay, it's like a plumbing system making its way home. You have your superficial, deep, and then you have connections between the two. So let's talk about the superficial system first. So one of the things that became very clear to me and to the group is that the superficial system is the dominant drainage system of the upper extremity. And remember, Hiro said, listen, he said, you have to remember that when you dissect out a cadaver, there are about 30 channels in the superficial system, and there's only a few in the deep system. And they're all about the same size. So if that's true, and you just think about how much volume any system can therefore carry, the superficial system must be the dominant system. And this is an important kind of anchor to have as we think through this process. And again, I want to say, even though this is focused on the upper extremity, these corollaries hold for the lower extremity. So, and we all agreed that the superficial system has two protective pathways, meaning if all those pathways going to the axilla or the armpit, those level 1, level 2 axillary node dissection areas were violated, well then there are two major protective pathways we believe the lymph in the superficial system will siphon out to. Pathway number 1 is what we call the lateral upper arm pathway, otherwise termed the Mascagni-Sappey pathway. And this is the pathway we introduced earlier. Well, as I told you, this was back in 2017 where we started getting very interested in this. So what we started doing was we took all newly diagnosed breast cancer patients and we started injecting them with indocyanine green right over that lymphatic channel. And we actually know where that channel is because anatomists have told us it rides with a vein. It's a very specific vein called the cephalic vein. So we use an ultrasound to find the vein and then inject it in the skin right over it. And we found the lymphatic channel actually goes right alongside the vein. And then we were able to show, using in vivo imaging, that we confirmed the finding by Kubik, who was another anatomist out of Switzerland in the 1950s. And Kubik in the 1950s says this Sappey pathway, this lateral upper arm pathway, exists in two different variants. In one variant, I hope again you can see my mouse, we know this pathway always exists in the upper arm, not always, but when it exists, which it almost always does, it exists in the upper arm. But in a long variant, it's connected to the forearm. Now in another variant, let me explain what I mean. It means if I just inject the hand, I will have a direct connection between the lymphatic channels in the forearm and this upper arm pathway. But then he described another variant, which is called a short variant. And in a short variant, when you inject the hand, all the drainage goes to the armpit. You have to do another injection right over that cephalic vein to find the short bundle scenario, to find the pathway. And this was really exciting to us because basically we were now able to demonstrate what he had demonstrated cadavers in living humans. And so we were now able to replicate his findings in patients. This is, we believe, really important because if you took out this main pathway here, which is draining to the armpit, and you have a long bundle, well, maybe that's a good thing because you're able to siphon all the fluid throughout the arm over to this other backup pathway. But if you have a short bundle scenario, well, then if you violate this main pathway, yes, you have a short bundle in the lateral upper arm pathway, but you have a gap. And maybe this gap can be overcome by some patients, and it can't be overcome by other patients. And there might be a multitude of factors that lead to this ability to overcome this bridge. But this became something that we felt was now more actionable because we could see it. And it turns out when we looked at a series of patients, that long bundle scenario is present about 2/3 of the time. That short bundle scenario is present about 1/3 of the time. And that the channel never being present was very rare. So this really began exciting us because we're like, wait a second. Now we're starting to see ratios very similar to the ratios of women that are going to get lymphedema or not get lymphedema given the exact same treatments. Now, I'm going to warn you right now, I wish I could just sit here today and say we figured it out. We haven't. It's much more complicated, but I do believe we're asking the right questions and we're going down the right avenues. This is work done by James Fanning, who was one of our recent graduates from our lymphatic research fellowship, who went on using our R01 funding to study this pathway further. And what we were specifically wanted to understand, and now we were looking at this healthy volunteers that were coming in, is, okay, we saw different variants of this pathway, but if we injected a nuclear dye right on the pathway, right here in the upper arm, where does it drain in the armpit? Because we felt this was very important to further understand how this pathway could be protective or not. And we divided lymph nodes in this armpit neck area into two types, station 1. And all you need to know about station 1 is these are lymph nodes a breast surgeon is likely going to remove if somebody has breast cancer. Station 2 are lymph nodes that are likely going to be left behind. So what we did is we brought these healthy volunteers in, 72 arms, and we injected them right over the pathway with this tracer that we can trace using nuclear imaging. Dr. Kevin Donahoe here at BI oversaw this, and we could see where they were going. And so it turned out that 96% of the time, it drained the lymph nodes a breast surgeon was going to remove. About a third of the time, it drained the lymph nodes a breast surgeon was going to leave behind. And 3% of the time, or very rarely, it never drained to any lymph nodes. What became very interesting, and this was somewhat serendipitous, is we noticed that the deltopectoral node, this was, if you recall, one of those early frames I showed you from that 1874 textbook by Sappey. In the future, I should put it right alongside this, but I showed you there's a lymph node here, and we'll come back to it. Turns out that lymph node, which is what I'm showing you here, only lights up in some percentage of patients. It doesn't light up in everyone. So the pathway is there, but that node isn't always there. And we became very interested in that. It turns out, I'm showing you the same numbers I showed before where, turns out when you have drainage to that deltopectoral node, your station 2 drainage goes up to 52%. This is in comparison to if it doesn't drain to that lymph node, then your station 2 drainage goes down to 27%. And this was statistically significant. What are we saying here? What we're saying here is station 2 lymph nodes are lymph nodes that if your arm can drain to, that's probably protective because those are lymph nodes a breast surgeon's going to leave behind. And it turns out when you have drainage to this specific lymph node, which lives right along this protective pathway we're studying, you almost double, or you more than double, the chances that you will have drainage to these protective lymph nodes. So we now believe this deltopectoral node drainage might be a biomarker of protection for patients with newly diagnosed breast cancer. All right, that was pathway 1. Let's go to pathway 2. Pathway 2 is called the tricipital pathway. The first pathway we talked about was here in the anterior arm. This pathway we're going to talk about, as you can see in the image, is in the back of the arm. Again, called the tricipital pathway because this is where your triceps are. And it's named after Kaplan, who was a world-renowned anatomist from Argentina. Unfortunately, he has since passed, but we have been fortunate to work with Professor Ciucci, who's also become a dear friend. Yeah, he's a vascular surgeon and a lymphatic anatomist at the University of Buenos Aires in Argentina, and he was Kaplan's disciple. And through an interpreter, he's been teaching us a great deal about not only the tricipital pathway, but many other parts of upper extremity lymphatic anatomy. And so we replicated what we did with the lateral upper arm pathway with the tricipital pathway. With this, there was an argument made that this pathway, the tricipital pathway, enters the back along the shoulder area and avoids those main lymph nodes removed by a breast surgeon. And so it turns out we found that similarly, about 2/3 of women have that long bundle scenario where the forearm is able to access this pathway in the upper arm going to the chest. 1/3 had a short bundle, and almost very few had no pathway at all. And this is a little outside the scope of what I want to dive into today, but this pathway is fed by different parts of the arm, or it can be fed by what we call the ulnar side, which is you take your little finger, run your finger down it, that's your ulnar side or your radial side. So we're seeing definite patterns on how these pathways drain certain parts of the forearm. And then we also have been studying where does the drainage go once it leaves the arm into the chest. So this is trickier to do because we don't have good imaging modalities that can really allow us to trace the pathway through its entirety from the hand all the way into the chest. All right, so that's our superficial system, and I wanted to spend the most time on it because this is the system that we believe is dominant, and I wanted to go over the two main pathways we believe are likely going to play some role in protecting an individual from developing lymphedema based on what variant we are able to image. Now we're going to go to the deep system. So the deep system is the system we talked about earlier that's below that fascia, it's deep. It usually rides with some of the main vessels supplying the blood supply to that extremity. And we believe, and this was made clear in our think tank through discussion, the deep system becomes more important when the superficial system is damaged. So, like we said earlier, superficial system is the dominant system. But when that system starts to get wiped out, there's going to be an attempt by the body to siphon fluid down to the deep system. Now, we think there are a couple of pathways here we need to consider. One is what we call the epitrochlear humeral pathway. So what I want to show you here is this. This was an anatomic study done on one cadaver by Hiroswamy. I think this was published 2007. And he took a woman who had an axillary node dissection, who had passed, unfortunately. She was a cancer survivor. And she never got lymphedema. And he dissected out the arm that was at risk, but never developed lymphedema. And then he dissected out the other arm as well. And he looked at these lymph nodes in what we call the epitrochlear region. This is a region right here by the elbow. And as you can see here in the top slide, this lymph node is really small. That was in the side that never had an axillary node dissection. And now look what happened to that lymph node on the side where the patient did have an axillary node dissection, but never got lymphedema. Look at the size, it's about 10 times larger, if not even more. Turns out the epitrochlear node is a highway between the superficial system and the deep system. And so this is, even though this was just one cadaver, this I think is very important early evidence that things do rev up in terms of superficial to deep drainage when the superficial system gets damaged. We became further interested in this as a backup system. And so we were working with incredible colleagues out in New Zealand, out in Australia and New Zealand. Dr. Reynolds, Dr. Chung, Dr. Swami, Thuranga. And they have this incredible database of over 20,000 patients who've had melanomas. Turns out when you're diagnosed with a melanoma, they have so many patients because of the sun exposure, given their geographic location. Turns out when somebody has a melanoma, you know which lymph node that melanoma drains to because you map it using nuclear dyes. And it turns out they had an XY coordinate system of every melanoma. So he said, okay, let's go ahead and focus in on the upper extremity. And I want to know how many in your 20,000 patients, and then the patients with specifically upper extremity melanomas, they happen to have a prior axillary node dissection for breast cancer before their melanoma diagnosis. And it turns out they had 22. So then I said, okay, on the XYZ coordinate system, where are those 22 melanomas? And as you can see here on this XYZ coordinate system, red represents where those melanomas were. And then I said, I want controls. I want to know anybody in your database who had a melanoma basically in the exact same spot. And I want to know what their drainage patterns are. How many of those do you have? And they had over 900. So I said, okay, so we have 22 patients who had a prior axillary node dissection, and we know their drainage. And then we had 900 melanomas basically in the same spot, and we know their drainage. Let's compare the drainage. How did it change based on the fact that the patient had a prior axillary node dissection? Of importance, none of those 22 had lymphedema. So this was our control group, 912. They're melanomas. We looked at them, and it's what you would expect. You'd expect almost everyone was draining to the armpit, level 1 axilla. The numbers go down for level 2, level 3. I want you to pay attention to this one number. This is epitrochlear brachial. That's a system that's likely connected, represents what we believe is that deep pathway, that superficial to deep connection. It was 9% and 4%. Okay? Now, let's look at the 22. What did we find? Well, this is what we found. Look at what happened to the brachial epitrochlear drainage. It went up. It went up from 9% to 23%, 4% to 32%. We also saw, not unexpectedly, a major fall in drainage to the level 1 armpit because the breast surgeon had been there previously, removed lymph nodes, and we saw increased drainage to level 2 and level 3. That is what we would have expected. This was also very interesting and confirmatory for us that this is an important backup system likely for patients after lymph node removal. So that's another protective pathway we believe that needs further investigation. And the final pathway is a pathway we are going to name in honor of Professor Ciucci, because he's the one who first described it in 1996, but it was only in the Spanish literature. So for that reason, we are going to be bringing this out in the English literature soon, and we are going to name it the Ciucci pathway. And this is a pathway that's actually, what you're looking at here is a hand, and what you're seeing is a pathway spanning the hand. It's going across the palm of the hand. And it turns out the center of the palm of the hand is a good place to connect the superficial lymphatic system and deep lymphatic system. And so when we do our injections, if somebody doesn't have any damage of their superficial system, you will not see this pathway. But if they have a backup in their superficial system, then the dye will back up into the back of the hand, swing around to the front, and try to go here. And why will it go here? It's trying to go here because it's trying to get to the deep lymphatic system. And so this pathway is a pathway we call the Ciucci pathway, and we are currently actively investigating this. And this is being led by Madeline Gavant, who's my Jobs Lymphatic Research Fellow currently. All right, so that's the superficial system, that's the deep system. And now, over the next 5 minutes, I'm going to try to bring this to a close because I want to make sure we have enough time for discussion. Let's talk about perforators. So perforators are what we talked about earlier. They're connections that are trying to connect the superficial system and the deep system. In a way, you can say that epitrochlear node is a perforator, but we kind of treat it a little differently because maybe it is kind of part of the deep system. But perforators would be channels that are connecting the deep and superficial system. And I hope I've convinced you that these probably dilate, they become bigger in disease as there's hypertension or increased pressure in that fluid in the superficial system. It's going to try to find a way to get down. And the only way it can do that is if there's a perforator. So these probably dilate in disease. And this has been shown by our colleagues in China, and they show that there tend to be perforators in the wrist. There tend to be perforators in what we call the antecubital region, which is this kind of flexion crease here. It was actually shown by Professor Ciucci as well in Argentina that there tend to be perforators again in the wrist, that antecubital region, maybe in the forearm, as well as the anterior upper arm. And also my colleague and dear friend Jaime Messia in Spain and Gemma Pons and their group have shown perforators in the wrist area, which we think is also very important. So these are areas that are being further investigated as potential areas where there are perforators, and maybe there are variants in these perforators. Maybe some of these perforators exist and are dilated in certain individuals and not in others. And only in those other individuals, some of them will be able to dilate it, some will not. And this will require further study to further delineate. All right, so that's your superficial system. Those are your perforators. That's your deep system. And what I want to just leave you with are some of the questions that we felt as a think tank are left for the scientific community to answer as it relates to lymphatic anatomy and imaging. One, and this is really important, is no single imaging modality that can be performed routinely, even at centers of excellence for lymphatic care, that can image a channel in its continuity from start to finish into a lymph node. And until we can do that, we have to piecemeal data together to figure out what's happening. Some of my patients ask me, Dhruv, why do I have to undergo 3 different imaging studies of my lymphatic system? And the reason is we have no good single imaging modality that can do it all. So we kind of have to piecemeal our data together. And this is where programs like ARPA Light, ARPA Glide, led by Kimberly Steele, are really working to try to develop imaging modalities that will allow us to do this, that will allow clinicians like myself to really move this needle forward and understand the anatomy and therefore become even better at the surgeries we perform. How do we image perforators? The deep system. This is really important because if perforators only get big when they're stressed, well, how do we stress a system in somebody who doesn't have lymphedema yet? But how could we potentially stress that system falsely to see if that perforator is going to get bigger or not? That was a really important question that we were discussing in our think tank. How do we better image these perforators in a normal state to simulate what might happen in a disease state? And then the deep system. I maybe spent a little more time on the superficial system. And I said, part of the reason I spend time on it is because it's the dominant system. Another reason I spend time on it is it's the only system we are decent at imaging right now because of the depth of penetration of our imaging modalities. We have trouble imaging the deep system because our imaging modalities don't really let us with good precision go down beyond 2 centimeters. So this is another area that really needs to be tackled. And I know there are really important efforts being made to do this. I'm not going to go into this slide, but this just shows the current technology that's out there and how some of the limitations of those modalities and why really on a clinical basis, we have to do multiple modalities to get a good idea of what's happening to the lymphatic anatomy. So in conclusion, I believe advancements in lymphatic surgery require improved understanding of anatomy. And I know there are many really important efforts occurring out there, not just with anatomy, but also imaging to make this to improve what we're doing in the operating room. I want to really give a shout out to my clinical team. I say this to them every day, and if any are on the call, they'll roll their eyes. Our secret sauce here is the team. It's the way we work together, the way we challenge each other every week when we have our multidisciplinary conference. We review new patients in our clinics. We all know each other's outcomes. And so nothing gets by any of us. We are always pushing, and we're pushing to make sure patients get the best care that can be delivered in 2025. I also want to give a shout out to my research team, really led by currently Madeline Gavant. She is our lead research fellow. She's spending a year and a half with us, dedicating her time to unlocking the mysteries of lymphatic anatomy. She's following James Fanning, was here before us, where I presented some of his data, and I think you're going to be seeing more exciting data coming from Madeline, she's really taken a deep interest, not just in the Ciucci pathway, but also in understanding what we can really interpret from ICG lymphography and trying to push some of those limits. And with that, thank you again, Bill, the entire LE&RN family. It really is a family. I felt that way interacting with them over the last decade for having me here, and I invite you all to come visit us in New England. Thank you again.
Thank you so much. Thanks so much, Dr. Singhal, for such a fascinating talk. And I know there are so many questions that are coming in, so I won't take much time. I like to start with some of the questions that we got early on. Is how safe is a knee replacement surgery when somebody has lymphedema in the same leg, both in calf and thigh?
Yeah, so thanks for that question. So that's a really important question, and it's not exactly well answered in the literature, but it is one that we address not infrequently in our center. So the scenario is an individual has lower extremity lymphedema. They might have it for a variety of reasons. They might have it because of primary lymphedema or secondary lymphedema. And we know with lymphedema, you have an increased risk of developing infections. And so now they need a knee replacement. And the orthopedic surgeon's like, I don't know if this is a situation I want to go into, because getting an infection of a knee replacement is a huge deal. It can cause a lot of problems. And so then it becomes, I bet you 10 years ago, maybe they didn't even know what to do with it. And they said yes or no, and they were done. And now we have centers of excellence. So now they're sending these patients to centers of excellence saying, you figure it out. And so it becomes a little bit of a back and forth, with the orthopedic surgeon of, how much are their orthopedic issues affecting their life? How much is their lymphedema affecting their life? And it often becomes joint decision-making. There is data in the orthopedic literature that does state there is a slightly increased risk of developing infections of the prosthetic if a patient has lymphedema. So we have seen it play out both ways in our center, where we'll say, okay, we'll take the patient to the OR. So let's say they have fat dominant disease, and say, we'll remove the fat and get control of it before you go ahead and do your orthopedic procedure. So it's a really important clinical question. And it is one that really does require joint decision-making, usually between the patient, the lymphatic surgeon, and an orthopedic surgeon.
Sure. Thank you so much for the answer. Another question that we have is, how effective is manual lymphatic drainage? I know we talked about so many alternative pathways. So is manual drainage going to help out? Waters technique? And it's supporting patient with lymphedema. How common is it used as a solution?
Yeah, it's a great question. I want to say something I say to my patients and I say to members of my own team, which is everyone more or less tries to stay in their own lane. I am not a therapist. And so I don't feel to be appropriately positioned to make a comment on manual lymphatic drainage. That's really something I would defer to my therapist, but I am going to make some thoughts on this as it relates to anatomy. I think manual lymphatic drainage, the idea of taking fluid and pushing it in a specific direction, right? This isn't haphazard. Therapists who do manual lymphatic drainage have a lot of training. And believe it or not, you shouldn't question it, this is the truth. A lot of what we understand about anatomy came from therapists. They have been the sole caretakers of these patients for decades. And so we've learned a lot about anatomy from them. That makes logical sense to me. And actually, we initiated a program jointly, the ALERT program in Australia. They are phenomenal colleagues of as we sometimes call them, our sister program, because we have joined multidisciplinary conferences with them. And they use ICG-guided MLD for the treatment, for example, of breast cancer-related lymphedema and other lymphedemas. And we have actually sent part of our team to Australia, learn this, they've brought it back, and we do this. So we create maps of the anatomy using ICG, and then we send it out with the patient to work with a local therapist for manual lymphatic drainage. And we've had some remarkable outcomes that patients come in terms of how they feel. So I don't want to make a qualifying statement on this only because I'm not a therapist. It's not what I do. But from an anatomic standpoint, especially if we can guide some of that, precision medicine, what's going on in this patient with their ICG lymphography, I could see how there's an important role for this.
Sure. Thank you so much. And I see there are a lot of questions about the lower extremity lymphedema and how modified drainage pathways can prevent further deterioration. Do you see similar kind of thing, what you showed in the arms? All these pathways, do they exist in the lower extremity as well?
Yeah, I'm happy to say, and that the answer is yes, that we do see accessory pathways. Like we talk about the epitrochlear nodes right in the elbow. Well, it turns out you have popliteal nodes right around the knee. And usually we don't see these nodes. Like if you ask any nuclear medicine physician who injects nuclear tracer in the feet in a normal state, you don't see these nodes. But we do see these nodes in lymphedema. We do see these nodes in altered states. So there are analogies here, almost one for one, that probably will be delineated out. As a team, I've made a strategic decision to focus the anatomic work on the upper extremity right now, because I believe once we unlock that, the lower extremity is just going to follow. But we can't help but see the analogies and study them as they come, as we have a busy clinical practice with many lower extremity lymphedema patients.
Sure, definitely. And another question is right up our alley is like, if there is a primary lymphedema in the right leg, do you plan to do similar kind of works, and will that help out in tracing this out?
Yeah, so that's a great point. So the question is, if somebody has primary lymphedema, is there a role for this anatomic work in that individual? Well, the high-level answer, I believe, to that question is absolutely, right? Because even with primary lymphedema, there's even though it's likely congenital in origin, it is somehow affecting the anatomy. Now, what we don't know enough of is it affecting the anatomy in that it's affecting a short segment, or is it affecting the entire lymphatic system, right? And that's going to require likely some merging, not just with anatomy, but genetics. Most patients who have primary lymphedema will not have an identified genetic cause. So I would say the anatomic portion of it might be more secondary to guide surgical treatment. But on the secondary lymphedema, where somebody has a normal lymphatic system to begin with, is where I think that altered anatomy discussion becomes something where it almost can prevent the disease entirely. But I do believe understanding lymphatic anatomy could play an important role in somebody with primary lymphedema, though I think there's other steps that need to be probably taken first.
Definitely something to discuss with their primary care physicians or the lymphedema experts that they are discussing it with. We see a lot of obesity associated with lymphatic diseases. So there is one question, is the obesity and adipose tissue that might impair the superficial pathway or the MS pathway? And you might actually try to look at the alternative pathways for this.
Yeah, so this is a really important question. I see this is from Angela. Hello, Angela. The answer is likely so, right? So we know, Dr. Aaron Green over at Boston Children's, he's a co-director of our Boston Lymphatic Center, which is a joint program between the Beth Israel Deaconess Medical Center and Boston Children's. He has shown data, and this is very clear, that as BMI goes up, as somebody's fat percentage goes up, their risk of lymphedema goes up. You can have an extreme BMI, never have breast cancer, never have radiation, never have a lymph node removed, and you will develop lymphedema. Now, why that is, I think Angela's theory could be true, right? Is it possible just the weight of that fat? We know lymphatics are more embedded anatomically, even in the OR. Trying to peel off fat from a lymphatic is its own effort. Unlike veins and arteries, which they kind of sit in the fat, lymphatics don't just sit in the fat, they're kind of incorporated in the fat. So you can see that there's a mechanical argument here that the fat, as fat goes up, it actually just physically impairs the lymphatic by its weight. There are other theories out there. I don't really think I can go into a lot of details in it just because of time, but we've been working with our endocrine team here, Dr. Westcott, Dr. Evan Rosen, to study this fat that occurs in patients who have fat-dominant lymphedema, which most patients do. And we compared the fat that we removed in a debulking procedure with fat in the normal extremity. And it turns out that the fat that's developing in the lymphedema extremity is a different cell line than the fat in the normal extremity. So there's more to the story that we still need to delineate, probably at the molecular level, to understand what's happening at that level. But all these theories, including the one Angela's putting forth, absolutely are in play.
There are so many other questions, but this one is really, I'm really inclined to ask you is, can ultra-high frequency ultrasound image the deep system and perforators? We're talking about different imaging modalities.
Yeah, it's a great question. And the answer, as far as what I know about ultra-high frequency ultrasound, we have our own machine, we use it, and we've discussed this actually in multiple forums. The answer, unfortunately, is no. It does not have the depth of penetration to image lymphatics at a depth. It actually has less depth than an ICG near-infrared camera. So unfortunately, it's a great idea, but no, it would not allow us to do that.
Mm-hmm. I think we are almost at time, Doctor. Do you have any last word for all the viewers, listeners, and the patients specifically who are like looking forward for making these discoveries on to some sort of therapy outcomes for them, how that can help out with them?
You know, I just left my morning clinic. I'm about to go into my afternoon clinic, and I was seeing a patient with breast cancer-related lymphedema, and she happened to walk out with me. She knew I was giving this webinar, and she said to me, you know, thanks for everything your team is doing in terms of, you know, bringing so much objectivity to this. And I said, you know, it's really exciting to be in this field. And I think I speak on behalf of all lymphatic surgeons, probably all lymphatic providers. It's really exciting to be in this field because you feel the needle moving. You feel headway occurring, even compared to 10 years ago when we started this center, where we are in terms of our anatomic understanding, then to now is night and day. And so I guess my biggest message that I want to give out is one of hope. I believe there is tremendous hope with what's happening at the scientific level, with the advocacy that LE&RN leads all the time, with the research funding coming into this, with the NIH, you know, ARPA. There's so many exciting things coming down the line that I just want to leave a message of hope with patients out there and excitement for clinicians that might be on this call as well.
Sure. And we thank you so much, Dr. Singhal, for spending such valuable information, such valuable time with us, and such an informative session we had today.